Hello and welcome to another fun Wise Women Wednesday, a time for us to get together and chat about all things birth. And I'm your host, Augustine Colebrook. And if you're watching this live, hey and welcome. And maybe you're watching the replay at my YouTube channel or on my website. So welcome to all those folks as well. So if you're just joining us, go ahead and just for fun, tell us where you're tuning in from. I always like to know where across the country or around the world we get to connect with all these lovely birthy folks. And then remember, today is a Q&A. So if you have questions about birth experiences, interventions, complications, a recent birth you were at, something a colleague told you about, if you want product recommendations or anything in that vein, if you have any questions, definitely go ahead and post those now. My fabulous assistant Bobby is keeping up with all of the posts so that I can not get them lost in the shuffle, because we have a lot of people joining us today, which is so exciting. So let me go ahead and see. I'm a grandma, so I wear glasses now. Don't mind me. Let me go ahead and see who is joining us. So let's see. It looks like we have Utah, Wisconsin, Santa Cruz, California, Texas, Oregon, Massachusetts. Gosh, we got the whole crew. That's so exciting. And I'm sure there's going to be more. So welcome, and if you have any specific midwifery questions, please go ahead and leave those in the notes, and we will get to as many as we can today. Some of the questions that people ask during this live Q&A is questions about outcomes or complications, sometimes a little more information about tests or procedures get asked. So really the sky's the limit. Anything that you have a question for, I will try to answer. And then of course I invite any of those senior midwives who are also tuning in today to also chime in the notes section. So it looks like we've got a nice big crew. Let's see who's joined us. Hey Angela, how are you? I see Melissa calling from Texas, Molly from northern Minnesota, Heather from Houston, Texas, Wendy's joining us from Tennessee, Billy's from Oregon is with us. Gosh, there's so many great people. Jessica from Mansfield, Texas, Joya from Santa Cruz, California, Gina from Wisconsin. Oh gosh, what a nice crew we have joining us today. Now remember, you can always post at the bottom of your screen. You can hit that share button, and then you can share it on your page or in a midwifery chat group that you think people might like to connect. Well, let's go ahead and start with content today and see if anyone has any questions that they specifically would like to chat about today. And especially you students, if you have something going on in your studies these days, something you'd really like to know, please let me know, because I want to answer those questions today. Well, while we're waiting for the first question to pop up, I am in beautiful Maui today. I've done these calls from all over, and it sure is exciting to be in this beautiful part of the world. I do have a practice here now, and we do take some traveling birth people. So if you live in a state that won't let you do trins or breaches or VBACs or things like that, and you have a mama you'd like to bring to Maui, you can come too. And we'll have a birth party out here in this beautiful, amazing place. I have an amazing Hawaiian midwife partner, Ki'i, and my new student, Leilani. So I'm hoping they'll join us today too. There she is. There's Leilani. She just popped on. Hey, darling. She's away at school in Maine right now, so we're making do without her. Can't wait till you're back. Well, let's see. I know that somebody was asking me this week a question about advertising. So let me start with that while you guys think of your questions. So a lot of midwives have questions about advertising, and I would say just in general, we do know that in most parts of the country, we have moved away from paper advertising and we are almost exclusively digital. And while social media advertising and Google ads can really get you a lot of traction, this is my little trick, my little reminder. I really, really encourage you all to make sure you focus on building your lists, because social media can change the rules about how you can access your followers. Even people who are like your page. Facebook is now charging us for the pleasure of accessing our own fans. So it's really important that you have control of your list and the people that follow you. And I'm going to have a lot more about this coming up in a business course we're doing this summer. So stay tuned for more info there. Let's see, it looks like we might have our first question today. This question comes from Joya, and let's see, what tricks to use when a birthing person with such intense after pains with a great clotting factor who has a cervical os close to the blood could be expelled? So let me see if I can understand this. So when your birthing person has such intense after pains, and her postpartum lochia is clotting really well, and the cervical os, it's clotting maybe before or above it's expelled. Yeah, okay, I think that's what you're asking. Go ahead and get clearer. If I don't have that question right, Joy, I'll go ahead and type a clarification. Yeah, so it's always possible to maybe have a woman whose clotting factor is so great that the blood is pooling in her uterus and clotting before she expels it. And of course, expelling clots can be quite uncomfortable. And additionally, clots pooling in the uterus will eventually form one big clot, which then can increase the rate of bleeding because the uterus will continue to grow in size as those clots grow. And then the blood will bleed more, and then more clots, and there's kind of this catch-22 that happens. So my main advice for this is actually prevention. You know, naturally, most women will choose an upright position to birth in. And this is for a number of reasons, biologically, as well as for comfort physiologically. And of course, my biggest advice is to encourage that in some form of semi-sitting or kneeling or squatting, hands and knees, even standing, and then to stay in that position for the entirety of the delivering the placenta and the first little bit postpartum. Now, if this continues for an extensive time postpartum, we might have another problem, and we might have a moderate uterine atony situation where the cervix has closed partly like it does early postpartum, but the uterus is a little bit laxer than it should be. So what we actually then see is that she's actually clotting. She's bleeding more than we would like to see. So in a normal circumstances, the baby is expelled, the uterus has a rest period, baby nuzzles at the breast, and then there is a resurge of oxytocin, which causes the uterus to contract again, which then causes the placenta to shear off the uterine lining and also be expelled. And then the uterus maintains strong and firm tone for the next 5 to 8 days. That would be the normal experience. So that the clot that forms initially is the size of the contracted smaller uterus, and it really isn't expelled for the first 6 to 24 hours. So we always say expect a clot maybe the size of your fist in the first 24 hours, and that's because that uterus is now getting even smaller and expels that clot. If we're having multiple clots, egg to fist-sized clots, then we actually have a trickle hemorrhage. So then you would treat that just like you're treating any hemorrhage. So let's see if Joy has any clarification here. Yeah, so with a rising fundus due to hemorrhage, yeah, let's see. Placenta birthed in under 10 minutes. Great, got that. And she was upright. and holding on to the baby and on her knees birthing. So Joy has a specific case. And she had a rising fundus due to hemorrhage. Yeah, absolutely. I mean, I think I know what you're saying, but essentially, we can't just watch for signs of bleeding to determine a hemorrhage. We also need to be fully assessing the location of the fundus, because a rising fundus can absolutely indicate bleeding behind the placenta and or behind a clot that has formed at the os. So I hope that answers your question. And of course, there's a whole nother set of education questions, comments that we could have about treating hemorrhage. But essentially, for clots, the best treatment is not forming in the first place, not bleeding excessively, and then obviously the work that it takes to expel them. And if you've taken my workshop, you know that I do recommend actually removing clots manually more than I prefer fundal massage, because if we do strong fundal massage, we're going to displace the uterus. It's going to drop down into the pelvis with those long round ligaments no longer supporting that free-floating organ, and then we can create all kinds of prolapse and pelvic congestion issues later. If you do end up needing to do firm fundal massage, do please recommend your clients see a Mayan abdominal therapist soon postpartum to lift that uterus back up into the abdominal cavity where it belongs, not shoved down deep in the pelvis. Okay, hope that answers your question. Let me see if I can jump to the next question. And hello, and if you're just joining us, welcome to our Q&A Wise Women Wednesday, and I would love to get to all of your questions if I can. So let's see. Oh yeah, okay, Joya. Yeah, it sometimes is concealed. Exactly. Thanks for that. So let's see. I know we have another question here. Let me just see if I can find it. I love it. Look at all these people joining us now. Okay, looks like we have a question from Gina. I'd love to hear some of your background. What was it like for you when you were a student? What were some of your struggles as a student? And how long did it take you to graduate? And where did you get your schooling and or do PEP? I'd like to be assured that I won't be an awkward student forever. Gosh, Gina, I love that question. That's fantastic. Yeah, you feel like it might go on forever, but I promise it won't. Well, for me personally, I was called to midwifery really early. I feel really blessed in my life. I kind of knew my path sooner than most. And I started being completely fascinated with birth in my very early 20s, and I lived in Europe for a year when I was 19, and just happened to be with a host mother who was the head midwife for all of Jutland, the main peninsula of Denmark. So I didn't go to births with her, but I definitely got soaked in the knowledge and the passion and the excitement of midwifery, and I got to learn from her a lot. And then when I came back to the States, I went to the College of Charleston in South Carolina, and I got the privilege of working with a CNM and a CPM in that area and really learned a lot there. I am a fully PEP process student. Over the course of my education, I had over 13 preceptors. I'm a huge fan of having multiple teachers and multiple mentors in our lives. It really gives you the opportunity to distill all the different ideas and techniques and procedures that you might learn from different providers, and really come to your own sense of morals about who you want to practice as, what's right, what's not, what's important. So I really think that having multiple teachers is a real benefit. I know I've heard it discouraged in the CPM world, and I don't know if that came out of NARM's verification of skills, having the second provider, or where that kind of thought came from. But I think it's wonderful. As many different teachers as you can get would be a definite benefit. So one of the other questions you asked is, you know, how long did it take you to graduate? Well, graduate's a funny thing when you're PEP, right? I started practicing before I was licensed because I lived in a non-licensed state. And then when I did go ahead and get licensed, I had been doing it for a while. And you know, you won't be an awkward student forever. You just have to, you know, there's that old saying, fake it till you make it. And I certainly don't mean like we shouldn't be misrepresenting ourselves, but at the same time, there's a little bit of like bravado you have to have, and a little bit of like sometimes false confidence. Hopefully you're doing that within a container, a safe container of senior preceptors who love and support you and want you to do really well and offer to help you through that awkward stage. But with clients, there's kind of this bravado you have to create in yourself and believe in yourself that you will know it, you will learn it, and even if you don't quite right now, that experience really does lead to expertise. I don't know, I would say there's the first time for everything, you know, and then there's a second, and then there's a third, and it's really important to keep having that experience, to keep having those opportunities to learn and practice. And, you know, if you're not in a good apprenticeship, if you don't have a preceptor who's really your champion and, you know, cheering for you, then maybe keep looking. Find that preceptor that exactly matches. And I've seen this before a lot of times, that there's like a right preceptor for the right stage that you're in. So certain preceptors are really great precepting like baby midwives, you know, like when you're right at the beginning and you're really passionate and excited but unsure and really brand new at everything. Some precepting midwives are great at nurturing that along and stoking the fire and all the positive affirmation. And then there's some preceptors that are really great for midwives, future midwives that are really in the bulk of their training. You know, they're kind of information warehouses and things just spill off their lips and they always have things to share, and that could be a good preceptor to find. And then I know that there are preceptors that are really much better at like finishing your education. They bring a little bit of a bigger dose of reality, or they bring some real like pulling on the reins. You know, I've had students, I've precepted a lot of students before, and I've had some students where it's like, come on, fly, get out the nest, you can do it, go do it. And I've had other students where I've had to be like, whoa, whoa there, Nellie, you're running a little too fast, you know. And so, you know, there's some preceptors that do better in that finishing capacity. So I would just say, you know, if you feel insecure, make sure and check in. Is that because you need more love and guidance and support? Or is it because someone actually isn't championing your cause? So yeah, take good care of yourself in that. Hope that answered your question. Obviously, write for some clarification if it doesn't. And Gina, thanks so much. Okay, let's see. We got people here from the snow in Minnesota. Oh my gosh. I'm in shock, right? I heard there's big snow in Minnesota and Wisconsin. Did a consult with a midwife in Wisconsin. I think they got 12 inches or something this week. It's amazing. You're going to hear chickens in the background. If you've never been to Maui or Hawaii, then you've missed out on the beach chicken phenomena. There are chickens everywhere. And so they're going to be here in my video. Don't mind me. Alrighty, let's see who else is on the call. We've got someone from Central Nebraska. Welcome. Gosh, so many great folks. Looks like Danielle has a question. Hey Danielle, good to see your little face here. What are your thoughts on approaches to writing practice guidelines for a solo midwife home birth practice when the state does not dictate requirements? I've seen a huge variation in level of detail, from a short list of AP, IP, PP, and NB indications for transfer to a detailed instructions for many scenarios, more like practice protocols. Alternatively, many midwives, although following evidence-based practice, don't have any guidelines specific to their practice. Pros and cons of these different approaches. Well, Danielle, this is a fantastic question, and boy, is it the issue of our times. Yeah, so I just, first of all, thank you for asking this. This is a huge subject. We might not be able to get as deep as you want, but let's try. So practice guidelines really are what they should be, guidelines. And the purpose of them is really twofold. I mean, the main purpose of practice guidelines is to help remind yourself of state law, policy and procedures, or, standard of care in your area, and what you decided previously you would do in certain circumstances. But it has a second benefit of creating a standardized care in a community, and it has a third function, and unfortunately this is to penalize midwives who go outside of the guidelines they previously determined where they were going to practice within. So they're incredibly important, not only as the guideline and the support for your practice, but they're also important because in the end, if you get a complaint or an investigation or a lawsuit, the practice guidelines that you have in your practice at the date of that complaint are what are going to be used to judge your practice against. So it is defensive midwifery to have good practice guidelines in place. Now, what is good practice guidelines? They are clear enough that they're not ambiguous, that they can be reproduced. You can replicate that choice, that decision, but they're open enough, and I don't mean vague, but open enough that you aren't going to be persecuted or hung at the stake if you do something different than the standard of care. So in writing your practice guidelines, I do recommend that you have pretty extensive guidelines that go through all of the tests, procedures, complications that we might encounter as midwives. A simple list of when you'll transport a client really isn't enough, and those aren't guidelines, those are protocols. And when you write protocols like that and you do something different, that's where midwives get hung. And I will say most of the time when midwives get investigated or are defending themselves in a lawsuit and they're found guilty, it's because they did not follow that practice protocol. So instead, we want to write guidelines, and guidelines create a whole sphere, like a window within which you could practice. Some examples. You'll need to have some practice guidelines on a client with a UTI, right? But those guidelines wouldn't be all clients get antibiotics, because there are some clients that could naturally treat their UTI. And if they went on and had a premature labor after taking a bunch of cranberry pills, technically you could be liable if they had a preterm delivery. Like if the client had the wherewithal to then go, my midwife recommended cranberry pills, and I know that in her protocols it says she's supposed to give antibiotics and she didn't. So you don't want to create a situation where you're creating liability. But at the same time, you don't want to be so vague that you could do anything with those options. So it's an art. Writing protocols is an art. But I do recommend that within your practice, if you're a solo practice, perhaps you want to get together in your peer group during peer review and spend an hour at the end of peer review every single meeting discussing a different complication or intervention and really sussing out what is the community standard. What does my community expect me to do? What am I comfortable doing? What does my license allow me to do? What do the physicians that I would transport to think I should do? And coming up with a guideline, a range of normal. So for instance, for this UTI issue, one is that with symptoms, signs or symptoms of a UTI, you would do a urinalysis. You would get definitive proof. So that would be an acceptable guideline. But it does lock you in. So instead, you might write, with signs and symptoms of a UTI, the midwife will recommend or offer urinalysis testing. Then with a positive urinalysis, the midwife will recommend a range of treatment from natural to pharmaceutical or transferring care. And that way you can use your clinical judgment in each situation within the range of the guideline that you create. Now, certainly in your area, you might need to be more specific. For instance, Some states' laws are so specific that if they have signs or symptoms of UTI, they must be treated and you must transfer care or have someone, collaborative physician, who can refer for meds. But I hope that makes it clearer. You want to create a window within which you can treat that doesn't make it so specific that you'll be, in trouble if you deviate, but isn't so vague that there's no steps to take. Now, if there is a very clear no-go situation, for instance, if you diagnose preeclampsia, I don't think there's anywhere in the country midwives out of the hospital should be taking care of that. So with a definitive diagnosis of preeclampsia, transfer patient. That would be acceptable protocol to put in your guidelines because there's no reason for you to deviate from that ever. Now, what you do need to be clear about is the definition of preeclampsia, right? Is it 2 or 3 symptoms? Is it a 24-hour urinalysis or +3 protein? Is it a blood pressure over 140 over 90 or 100 over, 150 over 100? Those are the kinds of things that trip midwives up, because if your definition doesn't match the physician's, then that's another place where midwives get hung up. Because let me just say this. I mean, I say this all the time, but it bears repeating. When we practice midwifery, we are not practicing in a vacuum. We are practicing with an entire competitive industry watching everything we're doing. And if you are complained against or investigated or, Lord forbid, sued, it's really important that midwives know you will not be on a trial with a jury of your peers. You will actually have a jury of your competition and or completely ignorant population. So in writing your protocols or your guidelines, you need to spell it out so that in the worst case scenario, it would be clear to the layperson what you're doing. And you need to not assume that your assumption of what a definition is or what normal is would be understood by the general population. Because, I mean, I heard this so many times. If midwives are on trial, they call in a subject matter expert. That's not a midwife. They call in the head of the OB at the hospital in your town. That's who they call as the subject matter expert. So if you deviate from your standard of care in your community, you need to put that in your protocol. So I hope that helps, or in your guidelines. So I hope that helps distinguishing them. If you have a clarification question, please go ahead and ask that below. And let's see who else we got here. And thank you for your patience as I scroll through this. So it looks like, hi, Jillian. Jillian's calling from Georgia, and Monica's on the call from California. Woohoo! Stephanie's on the call, so great. Case from Utah. Kelly, that's so great. Oh, Gina, I'm glad I answered your question. Laura, hey Laura, how you doing? So great to see all these people. Stars on the call from Mississippi. Hope's from Texas. Barbara's tuning in from Puerto Rico. Hey girl. Okay, so it looks like Monica has a question. And again, if anyone is joining us and has a question today in midwifery related topics, go ahead and type that in. So Monica has a question. I need an abbreviated charting terminology to help one of my students do shorthand for charting. If you happen to have that list somewhere and can direct me. Yeah, I do totally have that cheat sheet. Let me think. It's probably in my Dropbox somewhere. Yeah. How could we get that to you? I know. When we find that, we will post that in the event conversation box for today's event. We'll post that in today's event. So thanks for asking. We will stay tuned to that. Let's see. We got a whole bunch of new people joining us. If you're just tuning in, go ahead and say where you're tuning in from. And again, if you have a question midwifery related that you'd love us to touch base on, go ahead and post a question today. So Danielle has a little clarification. So sounds like they should be extensive, semi-specific, but with open language when appropriate. Yes, that is exactly it, Danielle. Thanks for that clarification. Yeah, it's quite a chore. Writing policy and procedures is definitely a chore. Well, look at that. Here's the modern world. My kiddos saying, hi, Mom. Hi, Abby. I love you. Alrighty. So we are here chatting about midwifery on Wise Women Wednesday, and I'm doing a Q&A. So if anyone has any specific questions about midwifery that you all would like to get answered today, or have a case study that you'd love to chat about, or really has any kind of topic that you'd love to explore, please go ahead and post that in the questions. I definitely have another bunch of minutes, like at least half an hour, so we can jump into fun and exciting, lots of topics. So let's see. I'm getting text from someone. Oh, sorry. I'm getting Facebook message from someone who has more questions. So let me just read this really quick. Aha. Okay. Alrighty. So I'm getting a question privately, so I won't name who that is, but I'm getting a question about when you have a primip, how can you tell when they are a good candidate for out-of-hospital birth versus someone who would need to be transferred or should not be out-of-hospital birth? So this is a huge question, obviously. So if the person who asked it wants to clarify, feel free and message me again privately. But essentially, risk assessment is the hallmark of this. And risk assessment is a huge topic. And certainly clinical risk assessment is one of the main skills that develops during your midwifery education. But additionally, we need to understand psychological, mental, emotional risk assessment as well. So this is a complex skill that is not easily taught in Facebook Live or even in 3 years of apprenticeship. So be gentle with yourself if this feels like a foreign concept or feels like a huge topic. It really is. But essentially, with clinical risk assessment, you're going to want to have a litmus test, if you will, a line by which you can compare this client's health status to what is considered normal in out-of-hospital midwifery care. So some of that is done by lines in the sand, like threshold numbers. Like a simple one is that it's standard for midwives not to take care of clients with blood pressures of 150 over 100. That's a pretty standard line in the sand. So if you had a client who came to you with primary hypertension and her blood pressure was 160 over 110, that would be an automatic reason not to take care of them. But there's risk assessment that is more like, instead of red flags, they're what I call pink flags. And you can get a couple pink flags together, and when you look at them through the lens of them on top of each other, we actually have a red flag. So those pink flags are more subtle, and they take longer to learn. And they might be things like, she has sort of an unstable living situation. She's been staying with her boyfriend, but sometimes she stays at her mom's, but her mom kicked her out because she's pregnant, and now she's kind of at her friend's on the couch, right? That's kind of a pink flag. It doesn't risk her out of home birth or midwifery care, but it's kind of hard to have a home birth when you don't have a home. Now, there are creative solutions, and friends have birth at each other's house, or mom's house, or grandma's house, or hotel births. I mean, Lord knows, we've all done crazy situations to help families out. But you get that situation on top of her feeling like there's no possible way she can afford to pay you. She has no income coming in. And then you put that on top of, the fact that her blood pressure is borderline. And those are all pink flags that add up to a woman that's probably not a good candidate for an out-of-hospital birth. The same thing can happen with just social situations. I've taken care of women where I can't prove it, but I'm very certain that we have an abusive, coercively controlling, narcissistic partner. I don't want to be in a situation where I am somehow being affected by this, mentally unstable partner. Especially in states where there isn't good support for domestic violence. And midwives are all mandatory reporters, so that would actually be a reason to support if you had some evidence. But even if you can't have the evidence, there are situations where your safety has to trump everything, because if you aren't around to take care of the next mama, what's the good of taking care of this mama? So there's different risk assessments that happen in the social and mental and emotional realms, as well as the physical or the clinical. And in terms of PRIMEPs, generally, if they're not diagnosed with a disease and they're not taking medication, they're basically low risk. So you need to use even extra feelers to look into the rest of their life to really see if they're safe and appropriate for out-of-hospital birth. Alrighty, if you're just joining us, I want to say big welcome to Wise Women Wednesdays. We're doing a Q&A today. Got some ambulance in the background, pardon that. There's also beach chickens roaming around here because I'm in Maui. So welcome, and go ahead and tell us where you're tuning in from, and if you have a question that you'd love to have answered in your preceptorship, apprenticeship, in clinical care, or tests, procedures. Do you need an equipment review? Are you interested in a big item purchase and want to know good brands? Or did you just have a birth and really want to check in about what happened, and is that safe and normal, and what happened there? So let me go ahead and catch up with these messages I've been missing while I've been chatting around. So yeah, looks like Rachel's tuning in from Maine. Hey, good to see you. And Kathy's calling from Apple Valley, California. And it looks like Anna has a question. Angela's on the call. Hola, how are you, sweetie? Okay, so looks like Anna has a call. So question, what are your thoughts on postpartum preeclampsia? Have you seen this? How should we be monitoring it for it? Great question, Anna. Yeah, so postpartum preeclampsia is a thing. It is very rare, especially for our healthy, well-fed, full-term mamas with good midwifery care. But it is definitely a real condition that we do need to be watching out for. Now, it is caught in the similar way that we would catch it in prenatal care. So we're going to have symptoms of spilling protein in the urine. We're going to have increased blood pressure, and we might have some pitting edema, headaches, blurry vision, double vision, seeing spots, and generally we would have a mom who just doesn't feel well. But the thing with postpartum preeclampsia is, I don't know if either we have a lot of misdiagnoses, or there's so many other sensations in the body postpartum that moms aren't as readily able to identify the fact that they feel really bad. So there's a lot of sort of fear around postpartum preeclampsia because it's missed a lot, or it's missed until it's really, really severe. So for midwives, that's part of the reason why we have this fairly intensive visit schedule postpartum, and why we have a fairly intensive vitals schedule immediate postpartum. So blood pressure is going to be your most significant indicator of postpartum preeclampsia because it's what you're assessing the most. And it's unlikely for blood pressure to spike postpartum, but certainly it's possible. So I think it would be appropriate to have vitals done, every 15 minutes or so for the first hour, and then every 2 hours for the next 2 hours. And, most midwives go home from a home birth between 3, 4, 5, 6 hours postpartum is pretty standard. Mom's eaten, baby's nursed, mom's gotten up and walked around and peed. All the vitals are normal, and midwives tend to go home. So we're not going to actually be doing a lot of extensive monitoring outside of that initial 4 hours or so, which is why this 24-hour visit is so important, because that's a time when we can catch an elevated blood pressure. So don't ever skip your blood pressure checks in prenatal or postpartum time frame. A woman can look fine and say that she's fine and still have symptoms of preeclampsia. Now, what's even more scary is, of course, HELLP syndrome. And HELLP syndrome is a silent disease of pregnancy because it is only diagnosed with laboratory data. It is not a symptom picture disease. It's very hard to catch HELLP syndrome postpartum, and luckily it's even more rare. But essentially, it's a reason for all midwives to have lab privileges, and it's a reason, if you have any concerns, to draw labs right away. So I always recommend that when you're doing postpartum visits, even as a relatively new midwife or as a senior student, if you're doing visits independently, I always recommend that you carry a blood draw kit, including the tubes that would be needed to do a PIH panel, because it can't hurt. I mean, we're talking about a $27 lab fee and 5 minutes of your time, and it could potentially catch a disastrous situation and allow treatment before we were in a real emergency. So yeah, I hope that answered your question. When in doubt, do labs, and definitely instruct your patients to call you if they have any symptoms out of the ordinary postpartum, and don't take those lightly. If she doesn't have a home monitoring a blood pressure cuff at home, then you need to send someone over to take that blood pressure and really check on that. Now, once we're out of the first 2 weeks postpartum, it's very, very unlikely for postpartum preeclampsia to develop. And that's when we start seeing them less frequently. But definitely instruct them to call you if they have any questions. So I hope that was helpful. Okay, let's see. Look at this. We got so many sweet people. Jack's from Williams, Arizona. Welcome. And Brittany's on the call from Texas. And Joey's on the call. Hey, ladies, how you doing? Alrighty. Kathy has a question. Kathy is dealing with a client at 32 weeks who barely communicates and has not kept up payments, and has been a no-show at 3 appointments and will not call back or answer her phone, late to care at 24 weeks. I want to cut her loose, but I can't communicate with her. I have no available appointments for her for the next 3 weeks. Would you just send a letter? I'm trying to speak with her and communicate the issues and give her an opportunity to change behaviors, but she's not making the same effort. Woo, Kathy, great topic. This is a problem all across the country. As midwifery care has become more mainstream and more popular, we have a more mainstream audience seeking our care. And those mainstream folks are really not appropriate for out-of-hospital birth because they don't take the level of responsibility that is needed when you're choosing out-of-hospital care. So absolutely, this is a perfect example of a client that is not a good out-of-hospital birth client because she has social and emotional and mental issues. These are all red flags in my book. No showing for appointments. In my office, I had a 2 limit. You no-show the first time, we reschedule. You no-show the second time, we charge you. You no-show the third time, we drop you. There's just no reason not to communicate, right? That's a red flag. And then on top of that, not being available. It is, I think we've got better reception going. Sorry about that. It's definitely needed that you follow a protocol, and this would actually be in your practice guidelines, is that you would follow a protocol that that demonstrates how you fire a client. And Kathy, if you want a really good example that is like legally vetted, you could look up the Oregon administrative rules for midwives. And there's a very cool, very clear protocol in the guidelines for practicing Oregon midwives that shows how to legally discharge a client from care. And it involves trying to reach them by phone and email, and then eventually sending a certified letter discharging them from care. If they additionally have risk factors where they might then not seek anyone else for care, or they might be a danger to their baby, you suspect drug use or domestic violence, then as a mandatory reporter, you also need to go ahead and alert all of the hospitals in your area to potentially expect this client with little to no prenatal care. And at that point, when I have discharged her from care, I would go ahead and fax my records into all the local hospitals of all, including the letter that discharges her from care, and a cover letter stating my concerns for her baby's safety. So this is obviously an extreme experience, but having practiced in areas of the world where there are some women making poor choices and seeking out of hospital birth to avoid drug tests or other investigations, you do need to protect yourself in documenting and sharing potentially dangerous information about clients. So hopefully that helped Kathy. Let's see, there's really no reason not to communicate. And then, yeah, sorry about that. I don't know why we had some communication issues. Hopefully you caught up. Hopefully you caught up. So Kathy, go ahead and respond to make sure that, you know, you got everything that, the follow-up on that. Okay. Alrighty. So let's see. Looks like we have a question now from Heather. So Heather writes, I know many of my fellow students and I feel the push to get through school and move into the actual practice of midwifery expediently, pushing hard to finish the demanding requirements of a MEEK education to the point of putting family and other needs to the side. I've also been cautioned that rather than getting easier in practice, it gets harder, more stressful, more weight to bear, more hours, such that other things we've put to the side won't have our focus after certification either. What are your thoughts on that? What is your perspective on moving into midwifery practice in a healthy way that means we can make this sustainable lifetime work? Wow. Gosh, that is such a great question, Heather. Thank you so much for bringing light and focus on this challenge that we have nationwide about creating sustainability in practice. And I think we're at critical levels now. We have more midwives than ever leaving practice. We've lost all 3 of our high volume clinical sites in the US. We have a shortage of training locations, and yet our demand keeps getting higher. So the workload is higher. So yes, we have a problem. Midwifery is currently not sustainable. However, I do want to bring some good news. The good news is that with some strategic planning and the right resources and as much streamlined and automated practice protocols as possible, you can create a business that you love. This is going to be actually the main topic of my summer business course through the Birth Business Club. So stay tuned for more information. We're launching on International Day of the Midwife, May 5th this year. So there'll be a big internet splash about that, about all that I'm going to be teaching. It's a 6-week intensive course. It's not cheap, but I think it's going to be totally worth it. I will say the best way to hear about that more is to go to my website and fill out the request to receive our newsletter. Then you'll get the email about that course that's launching. And my website is wisewomeneducation.com. But Heather, going back to give you a few pointers, basically it's really important that you accept the idea that you need to change the status quo and do things differently than the preceptors before you did them. And one of the main ways is not being the solo everything. You need to bring people into your team so that you aren't the one solely responsible for making sure that every single detail gets done. There's enough to be responsible for when you're just the midwife, right? Being responsible for another person's life and death and their baby is enough. So we need to offload some of the business administrative skills, some of the advertising, some of the patient follow-up, some of the charting. So it's really about creating a team. And that's going to be my biggest free piece of advice, is having people that you can delegate to, because we all function better really as managers. That's what midwives do best, right? In all of your education and everything that you've been taught, the main thing that you're learning how to do is you're learning oversight. You're learning how to look at the big picture, right? When you're in a birth room, whether it's home, hospital, probably not hospital unless you're CNM, but whether it's home or a birth center, when you're in a birth room, you are thinking about that mom's emotional status, that papa's emotional status, that grandma's emotional status. You are thinking about heart tones. You are thinking about equipment. You are thinking about timing, distance to the hospital, how much she's drank, if she needs an IV, where your student is, what your student's doing. You're thinking about charting. You're thinking about everything. That is management, right? So because you've developed this highly attuned skill at management, it's important that you create a business and a practice that allows you to be the manager, not on the ground floor doing all the minutia, but in the high tower with the look out over the entire situation. So there's some simple tips and techniques that I've developed over the years of running birth centers and large home birth practices that allow you to do a quick audit of your business and of your practice so that you can see the missing holes and plug them quickly. The reason midwives say it's more work is because they are piling all the work on themselves. There is an amazing bevy of practitioners, of service providers out there that also are entrepreneurs and excited to help take some of the weight off your shoulders. And believe me, it is way cheaper than you think. Bookkeeping is a perfect example. Bookkeepers should never, ever be undervalued. They're awesome. And so midwives, I recommend every one of you have a bookkeeper. This is an independent care provider. You don't pay taxes on her or anything. You just pay her the paycheck for the hourly work that she does. Most bookkeepers are between $15 and $30 an hour, and you're gonna need them for between 1 and 5 hours a month. That is a totally affordable price for them to reconcile accounts, for them to handle payroll, quarterly taxes, help you prepare your taxes at the end of the year, be a go-to resource for all things finance, create a budget with you. I mean, this is an amazing resource, and you should have this resource in your back pocket. So, you know, that's just one example. There's going to be many, many different ideas. I'm presenting the course I'm teaching this summer. Stay tuned for more information. And I hope that scratched the surface for ways that we can help make this a sustainable practice. Alrighty, let's see who's next. Awesome. Okay, so let's see. Kathy, we answered your question. Okay, looks like Angela has a question. Can we talk about support systems in place with other birth workers and the importance of following through when you commit to helping other birth workers and clients? I had a placenta not delivered to a mom for 12 days that were waiting on her placenta healing medicine. It's so upsetting when you think you could rely on each other, but it might not be in certain circumstances. This field is so big yet so small. What is the right way to approach when a fellow birth worker doesn't follow through on her word? Yeah, Angela, that is so frustrating. And thanks for that question. Yeah, such a big topic. Well, you know, overall, I can just say that, you know, there are unethical business people in all fields. So don't think that this is specific to midwifery. There are unethical dry cleaners, and there are unethical tax accountants, and there are unethical doctors, and there are unethical, you know, bartenders. You know what I mean? Like it's the whole, every industry has this challenge. So try not to feel like victimized or singled out in midwifery. Spend some time really like calibrating your bullshit detector. Like, There are unethical people across the country in every field. So figure out how you can tell the right ones from the wrong ones. And even people who are ethical and have integrity and want to do the right thing sometimes have shit come up in their lives. So also grow your forgiveness muscle and just try to send them love and light, while at the same time being clear about your bottom line. So if this happened one time, and this could be with a client or with a colleague or with a student or, you know, anyone that I'm working with, if a missed deadline or a dropped ball happens with anyone, I come at it with love and appreciation for the things they do right. And I say, you know, this is kind of a bottom line for me. When I depend on you to do A, I really expect it to be done in this time frame B. And so how can we make that work for you? And sometimes if you come at it just with a lack of antagonism and lack of aggression and just have compassion, you allow for shifting in reality and big feelings to come up. So sometimes that person will confide in you that they just had a miscarriage and they didn't know who to turn to because they thought it was private, or they're in the middle of a divorce, or their mother-in-law is visiting and she literally makes them crazy, or any number of things. Sometimes they'll just be really honest right back and be like, I totally fucked up. Sorry about that. Sometimes, you know, because they haven't done their own work, there's still excuses or justifying. And then it's clear to you that maybe that's a person you're not going to work with again in the future because, you know, they're not doing what they say they're going to do and they're not directly honest back with you. So, Angela, I'm really sorry that happened. As you work through repairing that situation, I do encourage you not to take responsibility for that person's actions. So don't over apologize to the client for that time frame, because it's not your fault. And we all think we're doing the right thing by apologizing over and over, but that actually just serves to lessen your position of expertise and demotes yourself in that client's perception of you. So don't own stuff that's not yours to own. You can say, I'm really sorry that happened for you. I'm really sorry that student or that midwife or that doula let you down, but don't apologize like somehow it's yours to take fault of. But anyway, yeah, this happens all the time, unfortunately, and the best you can do is try to work with people that have integrity, be clear about your boundaries, and move on if you need to. So hope that helped. Alrighty, let's see who's next. Oh, look, there's so many of my favorite people on this call today. Hello, friends. If you're just joining us, go ahead and say where you're tuning in from. And if you have a midwifery specific question, do please ask us, because we want to know and answer all those questions. I'm seeing another private question come in through Messenger, and this might be the last one we have to answer today. So, let's see, this question is asking about AROM. So this person, who I'll keep private because they're asking privately, wants to know about when it's appropriate to artificially break someone's water. So let's go over this really quickly, because this is a big topic in midwifery. We have this really hands-off approach, and to kind of answer this question, I want to talk to you about how the pendulum has swung over the last bunch of decades in midwifery. So remember, the resurgence of midwifery happened in the late 60s and early 70s, and it was birthed again as a reaction to the highly medicalized scopolamine twilight era births in the 1950s and 60s. So women were literally knocked out and had their babies drug out. They were tied to beds. Fathers were excluded from the experience. Babies had all number of injuries from forceps. And then they spent upwards of 10 days in a nursery, and very, very few were breastfed. So out of that fairly barbaric practice of obstetrics, midwifery was born again out of necessity, because midwives really had to experience something different than assembly line obstetrics. So the first sort of reincarnation of midwifery in the U.S. was reactionary. Midwives were doing everything they could to do it different than what the OBs were doing. So if you can picture that, the fulcrum, the pendulum is swung way, way up here, and it's everything in obstetrics is bad. We want to avoid it at all costs. So consequently, the interventions of obstetrics was seen as very negative and something to avoid. And I think, we're swinging hopefully more towards a normal, which is trying to find a balance where all techniques, all complications in obstetrics were developed to solve a problem, right? So if you can think about it that way, every single technique, every single intervention, every single tool was invented to solve a problem. The problem in American maternity care system is that those tools or techniques have become overused, right? So a cesarean itself is not a bad thing. Cesareans absolutely save the lives of mothers and babies. I am a perfect example. I am alive because I was delivered by cesarean after a 6-day failed home birth. My mother was in labor for six days, and I was delivered via classical incision with meconium staining and high fever, and we both almost died. So she definitely gave it the college try. She tried everything she could to have that home birth, and still could not. So cesareans absolutely were invented to solve a problem, and they absolutely create safety in certain circumstances. Now, a cesarean rate over 30% does not create safety. We all know it's the overuse of the technology, not the technology itself. So when we think about all of the techniques and all of the tools in midwifery and obstetrics, what we're trying to find is the middle way. We're trying to find the balance of when that tool or technique creates safety instead of decreasing it. And so I feel like AROM is another perfect example of this sort of perception change that needs to happen. So artificial rupture of membranes can really be disadvantageous. We remove the cushion for the baby. We remove the cushion for the cervix. It can increase the risk of infection. It definitely can increase the risk of cord prolapse. And so there's reasons to be cautious with this intervention. But AROM also can solve a lot of problems. I'm sure if you've done births long enough, you've been at one of those births where a mom has a bag of steel, is what I call it. It's like, it's so tight and so firm, it doesn't mold at all, even with incredibly strong contractions. So it's kind of like this over-distended uterus is going, and there's no real pressure on the cervix, and it can't get any traction, so to speak. And so we have this long, delayed, prolonged, protracted, ineffective labor. And without treating that, eventually we get maternal exhaustion, which leads to fetal distress. So the simple intervention of releasing that bag of fluid allows that baby's head to come down on the cervix, allows contractions to be effective, and allows us to then have a smooth and effective labor and delivery. So it's really about finding the middle way. So when we're talking about AROM, we need to think about a couple specific things. Number one, how high is that baby, right? What is the relative risk of cord prolapse? Number two, how long do we propose she will be with ruptured membranes before she delivers? In other words, how increased is her risk of infection? What is her GBS status? And then lastly, what does this parent couple want? I've said this before, but I'll say it again. Midwives should never be the ones leading their clients out on the limb, right? We always must be led. This is the hallmark of midwifery, is that we are individualized and mother-led. So if she doesn't have enough information to even have an opinion about this, then it's not your job to encourage her to lean out on the limb, right? And then lastly, the other thing to think about is the standard of care. So if the choice is AROM or transfer, what do you think the first thing they're going to do at the hospital is? AROM. That's standard of care. So it becomes a much lower risk for you to offer because it actually is standard of care. So I hope that sort of bring some clarity. Ultimately, I think that AROM is underutilized in midwifery care and could really prevent some really long dysfunctional labors, could help with labor induction techniques, and certainly could decrease some of the transports, because it's honestly the first thing they're going to do when you get to the hospital. So we're going to wrap up this call. It's been so fun and so amazing to connect with you all today in this gorgeous, sunny, amazing Maui day. If you enjoy these Facebook Lives and you want more of them, go ahead and message us, connect with us. If you post here on in the event page for this event, or if you private message me, I'll definitely see that. And if you haven't yet, go ahead and join our newsletter on the website, wisewomeneducation.com, and then go ahead and enter your email. So it was a great pleasure to see you all today. Thank you again for all that you do for mommies and babies and for midwifery. Remember, we need more midwives. So anything you can do to help train the next generation, please do that. All right, friends, it's been a joy. Have a fantastic day. Take good care of yourselves and each other. Bye.